Hello, everybody. We're going to be talking about pre-op and post-op in this lecture. As you guys know, I have everything really in my PowerPoints. I've got a lot of information in there, down at the bottom so that you guys can read my notes and generally, my thought processes as I'm going through and preparing the lecture. So, as you guys know, that there's several types of surgery, and they're categorized according to where the surgery is, the location, the specific procedures. Why we're doing the surgery. Is it for diagnostic purposes, for cosmetic purposes? Urgency is also a really important one. Is this an urgent or emergent surgery? Because those are obviously going to be those that we don't really have time to think about. We just have to act with some of those. And then, of course, elective is something that the patient decides on in advance. And then the degree of risk is another thing that we are thinking about when we're talking about surgery. So when we're talking about elective surgeries, now those obviously are, as you guys already know, those aren't something that are really, really urgent that have to be done right at this moment. Those are things that are elective. When we have a patient that has elective surgery, there's some things that we can plan ahead for. If the patient is going to possibly need blood, they can, go to the blood bank and save some of their blood. These aren't things that can be done with an urgent surgery or with an emergent surgery. Of course, the patient is much healthier when they're having an elective procedure as well. So, I just want you guys to think about those things. Of course, urgently must be done within 48 hours. Now, of course, you can have an urgent surgery that can turn into emergent very quickly. So, I just put it on there so that you guys can see the difference in the time constraints with these surgeries. So, of course, when we've got these elective procedures, as I said, the patient is usually in better health than they are if it's an urgent or emergent case. So usually, the disease or infectious process or inflammatory process, it's not as advanced as it is with the urgent or emergent. So it's a lot easier to for patients to handle. Usually, it's typically a minor thing with our elective surgeries, and then of course our urgent and emergent are typically our bigger surgeries that are more serious. I put terminology on there for you guys. It's a lot easier if you know what in this case it's the suffix instead of a prefix. But I do have some prefixes in there as well. It's really easy if you guys know your medical terminology to understand what surgical procedure is going on. So I just put that in there as a review for you guys. Now, when we're talking about surgery, we're talking about the perioperative period is what we're going to be talking about. And that's the whole kit and caboodle there. That's the entire surgical experience. That's from pre-op to discharge. So there's a lot of people that these patients are going to be seeing in that time period. They're going to be seeing, of course, their doctors. So there's going to be office staff. There's going to be the nurse in the office doing some of the pre-op teaching, or it may be done at the surgical center. There's just a lot of people that they're going to be talking to. Of course, depending on the surgery, you may be seeing a physical therapist for an assessment. They may be telling you what you're going to be doing after surgery. I mean, every place is different. Most places don't necessarily do it quite this in depth, but there are several places that do. I know at certain hospitals that they will do a walkthrough of the unit with patients that are really nervous, or if they're going to have a serious procedure, then they will take them to a room that's set aside, and they will show them what's in that room and what it's going to look like. Of course, it's obviously if somebody's having a more serious surgery and they're having to go to the ICU, there's more bells and whistles and tubes and chaos and things in those areas than there is on the floor. So patients typically tend to be a little bit more nervous about this, and so there are certain facilities that will allow you to come in, and they will show you what the IV pump looks like, and he's going to be intubated and on these machines, and different things along those lines. So those are some things that are done in the perioperative period. Of course, your role as a nurse, you're going to be getting the patient ready for surgery. Uh, and of course, if you are an OR nurse, then you're going to be obviously in there and you're going to be assisting the physician and watching the patient during the surgery. And then, our main goal, we want to prevent and treat post-op complications as well. Um, it's one of those things that those can happen very quickly. So, you have to be in tune with what's going on in the post-op area just as much as, of course, the pre-op area isn't the same, but post-op complications can happen very quickly. And of course, getting the patient ready for discharge, because there is a lot of education that goes along with that as well. Now, remember that you have to have a complete history and physical. Now, if we're talking about one of these elective procedures, of course, those aren't as serious typically, and they're not, the urgent emergent. So usually with those, we can, do within a 30-day window. Now, Medicare has some other requirements that they like an update within 24 hours before the surgery. So, you may have to do a little bit extra with those patients. But typically, there's a 30-day window on most of the outpatient, especially procedures. So what are we looking at when we're doing the assessment on patients? We're looking at their risk level. Of course, age is a big thing. Of course, the older we are, and the younger we are, or, if we've got a health history, if we've got a lot of coexisting or comorbidities, of course, those patients are going to be at a higher risk for having complications. So those are all things that you're going to be looking at when you're doing the patient's health history. Of course, functional ability is always a really big thing, because we want to see how well the patients are able to function. So if we've got a patient that lives alone, that they're diabetic, or there's all these things that we have to worry about. We're going to be having to worry about these patients more. Of course, if they're diabetic, they're going to be at risk for slower healing, obviously, and their blood sugar is going to be out of whack. And we're going to have to talk about foot care, and there's just a million different things that you guys already know about, but I just want to throw the functional ability in there. If you've got a patient that has issues with their blood pressure and it runs low a lot, then we're obviously going to worry about them, having some orthostatic hypotension and things along those lines. So safety is a really big key with these patients. So we're going to be checking all of these things when we're doing this preoperative assessment, and see what the patient needs and see what we can do for them. Now, I listed some of the things that you're going to be, looking at, the age, the allergies. Now, always remember to ask what their reaction is to the medicines, because as you guys know, there's a lot of patients that say, I'm allergic to this antibiotic, or I'm allergic to whatever it happens to be. And it may be that it caused them to be sick at their stomach. That's not an allergy. That is a side effect for some people, or just not a fun side effect. So it's always good to ask their reaction to it. Now, if somebody has a true anaphylaxis to a medication, obviously we're not going to want to give that. But if they've got a sensitivity to it, and we are in a pinch and they need this type of medicine, say it is an antibiotic and they've got some sort of infection, and we've tried every other antibiotic and this is our last resort, we want to know what their reaction is to it. If they just get a small GI upset, we can give them some Pepsid or something along those lines to help their stomach, and give them the medicine. And of course, if it's something that the patient really needs, sometimes we'll give them Benadryl and go ahead and medicate them. So, it just depends on those things. But I want you guys to be thinking of why we need to be asking about their reaction to the medication, or whatever is their allergy that's listed. Now, of course, we've already talked about a lot of these things. I do want to talk to you guys about some of the different herbal and nutritional supplements that we want listed. St. John's wort is always a big one. Feverfew, black cohosh, fish oil. I'm trying to think of some of the others, but there are several herbal supplements that we definitely want the patient being off of for 2 or 3 weeks if possible. Some of them cause problems, and whether it's thinning your blood or things along those lines. But those are some things that we really need to ask patients specifically about, because we definitely want to limit their exposure to these things. I mean, it's just like saying, oh yeah, go ahead and take your aspirin up till the day of surgery. Those are things that we typically do not want to do. So we definitely need to think about these herbal and supplements when we're doing the history and physical on these patients. Also, I did have on here the previous effects from anesthesia. Now, there are some people that have big sensitivities to being put to sleep. If you've got somebody that comes in there and says, oh yeah, I had, it can be something as simple as, yeah, I had a mole taken off and I passed out and had a seizure afterward. Well, obviously we're going to get them up slower. Yes, I had a reaction to some Demerol that they gave me in the recovery room, and I stopped breathing, and I was on a ventilator for a week. All of those things, we really want to know the previous effects from anesthesia. So I just wanted you guys to think about those things. Now, when we're doing our neuro assessment, we definitely want to make sure if they've had a history of a stroke or a TIA. Of course, there's a lot of patients that come in that are going to have like a carotid endarterectomy. Those patients, they are at a high risk for a stroke or a TIA. We're unclogging those carotid arteries, and so they can throw a clot really easy. So, we're definitely going to be doing a neuro assessment and see if they've had any problems in the past. Not just that was just an example, obviously. If a patient is pregnant, we need to know what trimester they're in, because obviously that depends on what medicine that we're going to give them. And I know that people don't think about it, but pregnant women do have surgery. I've seen several pregnant women have cholecystectomy. I've seen them have appendectomies, things along those lines. So I always throw the pregnancy in there and the trimester, but also, since we're talking about this being a preoperative assessment, I personally do, if you are of childbearing age, if you have not had a hysterectomy, if you have not gone through menopause, then you get a pregnancy test. I've had lots of people that have wound up pregnant at 60. It happens. So, I want you guys to think about that as well. Obviously, if you've got a lactating woman, and they're breastfeeding, that's going to be something that we're going to be doing a lot of education on, because, we don't want to pass along these medications to the baby. So, just be thinking about these things as you guys are doing your preoperative assessment. Now, mobility issues are a big thing. Anytime a patient has surgery, typically they're on pain medicine afterwards. So, anytime they're on pain medicine, we worry about constipation. People aren't moving as much after surgery. So, if we're not up and moving, then we can have some serious issues with constipation. Of course, skin breakdown occurs in there as well, and not moving, we can have DVTs. Not moving, we can have pneumonia, atelectasis, all of these things. So I want you guys to be thinking about these things and what can occur. And so as we're doing our pre-op assessment and the teaching, we're going to be telling the patients these things. We want you to drink lots of water. We want you to move. We want you up and moving as soon as possible. So these are all things to think of. Now, I want you guys to think about a patient's jaw and their neck as well when we're thinking about a pre-op assessment. There's a lot of people with TMJ. A lot of people. And you have to make sure that they can open their mouth wide enough. Now, of course, the anesthesiologist, when they come in to see them, which is right before surgery, they're going to be having them open their mouth. They're going to be looking in their mouth. Of course, they're looking to see if they've got any false teeth or any teeth that look like they might break. And I mean, we don't want them inhaling their teeth and sucking it down their lung when we're intubating them and get them ready for surgery. So all of these things are things to think about. But, as the patient opens their mouth, if they can't open it very wide, it's really hard to get down in there for a procedure or intubate them if they're, doing an oral procedure or, try to scope them. If, we can't get the bite block in, it's really hard to do these things. So we want to make sure that they have really good function of their jaws. And also, if they have some neck issues, they're going to be, think about the positioning when you intubate somebody. You're going to be pulling that jaw chin. Remember, we're going to be opening that up, pushing their neck back, pushing their head back so that we've got access so it's a straighter line to intubate them. So neck problems can definitely cause some issues when we're talking about operations. If your patient's had bacterial endocarditis or, has valve issues or things along those lines, you're going to have to be thinking about antibiotic prophylaxis. If a patient has COPD or some severe asthma, we normally do our traditional pre-op, our UA, urine pregnancy test, our CBC, BMP, all of those things. But these patients may need PFTs. If they're a smoker as well, that may be something. If they've got poor lung function, that we may want to do something along those lines. So just be thinking about that. That may be something that we want to mention to the physician. Hey, I just don't know about this. Do you want me to get some PFTs? Now, anytime we're talking about smokers, now they are more sensitive to medicines, like our anesthetics and narcotics and sedatives. All of these things, they're respiratory depressants. And so we worry about hypoventilation. And we also worry about pneumonia or atelectasis. So any of these patients that we've been talking about, the COPD, asthma, smoker, they're all more sensitive to these things. So we have to really watch these patients. Now, if we've got patients with kidney issues, if they've got some renal failure, they may need dialysis. They're at a higher risk for an MI. So patients with renal failure, we have to really watch them closely. If they can't filter out all of these medicines that we're giving them to put them to sleep, then we may have to filter that out for them so that they come out of it quickly. If you've got somebody that's kidney function is terrible, then all of these drugs are going to stay in their system until something can filter them out. Well, so, I want you guys to think about those things. Now, I talked about diabetics earlier. Of course, anytime you've got a diabetic, they're at increased risk of some heart issues. Of course, surgery is terrible for them because their blood sugar is, it does go crazy typically. Hypoglycemia, hyperglycemia, ketosis. Of course, patients sometimes are on steroids after surgery. So sometimes with the steroids, they definitely mess with the blood sugars, bring the blood sugars up. And also, we've got delayed wound healing as well. Now, immunosuppressed patients. Now, surgery, what it does is it depresses the immune system. And that usually is about a week. So if we've got immunocompromised patients or cancer patients or HIV patients or, anything that's immunosuppressant. Of course, we have patients that have conditions and we've got them on immunosuppressant medications as well, like our patients with Crohn's and things like that. We have them on medicines trying to decrease their immune system because they have an autoimmune disorder. So all of these patients are at risk for issues with after surgery. Now, of course, morbidly obese patients, when you think of it, you automatically go with, wound dehiscence or evisceration, but they have breathing issues as well. A lot of patients that are morbidly obese have breathing issues and maybe on CPAP or BiPAP or something along those lines. But it's very difficult to position them as well. And so, those are going to be things that you're going to be thinking about from an OR perspective as well. You may have a special room that's got a bed that can accommodate a patient that's over 500 pounds or things like that. But those are things that that you're definitely going to be thinking about when you're doing the pre-op assessment. Patients with anemia. patients with abnormal clotting factors, we're going to worry about their blood situation. We're obviously going to be tapping and crossing these patients before they have a procedure. So all of these things we need to think about ahead of time. Now, when we're talking about their medicine list, obviously, we're going to write down what medicine they're on, but we also need to know the dose, how often it's taken, when it was last taken, and what it's for. There's a lot of medicines that are dual purpose or, a lot of times more than that, but so we need to know why they're on them. Always a good thing. Oh, I did forget to mention, and it just hit me, when we're talking about smokers. Now, typically, of course, now this doesn't apply to all smokers. Some people have smoked for 20 years and do great with it, but it definitely is one of those things to think about. Nicotine, what it does is it slows down and damages the mucociliary clearance system, right? You guys remember the cilia, the little finger-like projections in the lungs, and what they do is they act like little fingers, and they pull all of this debris and all this gunk up, and they get it to the bronchial tree so that we can cough stuff out, right? We don't like stuff in our airway. It's not supposed to be there. So anyway, we have these little cilia to help us get stuff out of there. So, a lot of times our patients that smoke, this clearance system doesn't work as well, and they do have a lot of gunk in their lungs. They've got a lot of mucus in there. So, I just wanted you guys to think about the extra secretions that they have. So, it puts them at a higher risk for pneumonia. So, and typically smokers, they have issues with, of course, the more damage and the longer they've smoked, then there's more issues. But they don't have as much oxygen available. They may have some vasoconstriction as well. So I want you guys to be sure to calculate the pack years whenever you're doing this. There's apps on phones. I'm sure that the computer, electronic, the EMRs will eventually get to where they calculate the pack years for you guys. But that's something that the physician will want to know. So, be sure that you have that information there. Now, another thing to think about is if you've got a patient that does any sort of drugs, or, there's patients that really hit those, certain drugs pretty hard, like anti-anxiety medicines, things along those lines. You've got your patients that take a lot of Xanax, is one of the big ones. When patients take these types of medicines, whether it's illegal drugs or prescription drugs, you can pretty well tell by looking at the patient. A lot of times they have a lot of tolerance to drugs, and it is really hard to sedate these patients. So, you really have to watch these patients, and it may take an elephant tranquilizer to actually get them to go to sleep. So, be very careful with these patients. I just want you to think about that. And if you're working in the OR, it's a little bit different than it is if you're working like in an outpatient surgery. If you're doing a colonoscopy on these patients, sometimes you give them an amazing amount of medicine. You're thinking, oh my gosh, I'm going to kill these people. It's very scary how much it takes to put these guys to sleep sometimes. Now, from personal experience, because you guys know that I was a circulator in endoscopy, so I tell you, I have gotten punched by a lot of these people. Typically, if they're hard to sedate, they will come at you fighting. So safety for yourself is very important. So I want you guys to think about this if you guys are going to be working in an area like this. Just because I've had it happen to me, one guy swung at me, and he wound up hitting the tech, and he broke her arm, and he tore a ligament in her hand, and she never worked again after that. So, he swung. He thought he was swinging backwards at me, but anyway, I moved out of the way, and I still feel bad about it. I'm glad that it didn't hurt me. I wish it wouldn't have hurt her, but it's one of those things that I want you guys to be aware of, that they typically come out guns blazing and swinging. So just really be careful with these patients. Now, I've got on here, I listed things by category, and I just kind of listed some things that I really wanted you guys to think about. Now, whenever we're doing our pre-op physical and we're doing our functional assessment like we were talking about earlier, we're obviously getting a baseline, right? We want a baseline before surgery because we want to see any changes that occur after they've had surgery or during. I mean, not typically during, but you know what I'm saying. So, really important to do all of these things. Now, a neuro assessment is really important. A lot of people don't think about these kinds of things, but there's a lot of things under that umbrella of the neurological assessment. We want to see their level of consciousness. If somebody was totally alert and oriented, and I mean, they were totally with it before they had their surgery, and then they 2 days later they don't know who they are, where they are. Houston, we have a problem. So really important with the neurological system. We want to see what they're able to do for themselves. Their ADLs, do they bathe and shower themselves? Because if they're doing it to begin with and then afterward they can't do anything, then we really have some issues there. Sorry, I had to take a second. My computer was fixing to die. So, now where was I? Oh, a history of falls. Obviously, that's going to be a big one. If somebody's fallen in the past, we're going to definitely need to use some fall precautions. If it's an outpatient surgery, then it's one of those things that we need to be doing an assessment of their home. Do you have a lot of fall rugs? Do you have 20 stacks of magazines in the middle of your living room floor that you might trip over later? Because there are a lot of issues with patients in their home environment. So that's going to be really important. Now, obviously, we think about, our patients going home and we give them their discharge paperwork and all is well. But, not everybody can read. Not everybody can write, and not everybody can understand at the level that we give them this information at. Now, as you guys know, it's typically on an 8th grade reading level is typically what most information is, but we can get it down to, there's lots of websites that you can find stuff on a 6th grade reading level. There are some that you can find that have pictures. So all of those resources are really important to know. If you've got a patient that's going to be going in for, let's say they've got throat cancer and they're going to be having a laryngectomy. Now, we need to be seeing up front how well they can communicate. If we've got somebody that's going to have a laryngectomy, we need to make sure that they can write so that they can communicate afterward, or that we've got some way for them to communicate with us after surgery. So, anyway, those are things that I want you guys to think about when you're doing this physical assessment and functional assessment before they have surgery. Now, of course, I've got everything listed on here, but I do want to throw in a couple things that I did add, like respiratory. If they use a CPAP machine at home, make sure that they bring it to the hospital if they're going to be there for a while. It's one of those things that the hospital doesn't have CPAP machines on hand, and of course, you're supposed to have them check it out and make sure it's not an electrical hazard or a fire hazard before they can use it. But all of these things are things that the patient may need. Now, I do want to throw in as well that, if a patient is going to be in the hospital for a long time, then obviously they're going to need more things than if they're just coming in for a day procedure. If somebody's coming in and they're going to have a colonoscopy and I'm doing the pre-op teaching, I tell them to leave their stuff at home. Now some people obviously want to have their dentures with them because they don't want people seeing them without it. Of course, if they've got glasses, they've got to see what they're doing. So, those aren't things I'm talking about. But, if somebody wears, 15 diamond rings and has diamond earrings that they wear all the time that are worth $1 million, I don't want them coming in there with them. So if it's something that the patient doesn't need, then, it's always better for them to leave it at home. Just be thinking about those, because I don't like being responsible for stuff like that. Now, I do want to talk about jewelry since I've mentioned it now. I don't want to forget about it. If you've got a patient that is, now our older patients are that I have found. It's more common for them. But I've had patients that have said to me, I've been married for 65 years and I've never taken this wedding band off. We're not going to make them take it off. We're just going to tape it on so that it doesn't get lost. So the patient still feels comfortable. I've had a lot of patients that really do not take off their St. Christopher's medal as well. And that's okay too. We can tape things on. We don't always have to take everything off of them and take everything away from them when we're doing a procedure. So just think about those things, that is okay to do. Of course, hospital policy may be different than that. So obviously check your hospital policy. Now, the thing that I also wanted to say is on integumentary, a lot of people have really thin skin, especially our older patients, because they've been on steroids, or as we get older, obviously our skin thins and we don't have as much adipose or fat tissue underneath for cushion. So they're really sensitive. So be sure and don't put that really, really thick tape on them. When it comes off, their skin comes off with it. So be sure and think about if they're sensitive and break out in a rash from certain kinds, paper tape's going to be our friend. Of course, if they're older, I use paper tape on them as well because they're very sensitive. Now, you're going to have patients that come in that are extremely anxious, that are freaking out. That's common for a lot of patients. Now, if they're having a panic attack, obviously you'll want to let the physician know about that. But, if they're really nervous, it's, if your hospital policy or your outpatient procedure policy, and most of them allow family members back there, have them, bring their family back. It's okay. Distraction techniques are a beautiful thing. A TV or family's the best distractor, but sometimes patients don't really want anybody back there with them. They just want to be back there by themselves, and you can turn the TV on, or crossword puzzle, or here's today's paper, or whatever. But distraction techniques are really, really good. Now, with patients that have diabetes, I always have them fill out a diary, usually the week before. Anytime a patient's having a surgical procedure, we're going to, if they're on insulin especially, we're going to give them some special instructions on when to not take, you're going to do everybody's different, but sometimes it's a half dose for the day before, or sometimes it's none, or, every physician's different with how they handle that. But I like to make sure that their insulin, oh shoot, come back. But anyway, I like to make sure that I know what their blood sugars are the week before surgery. Now, I also wanted to mention to you guys that okay, there it comes. Okay, we're back. Sorry, I thought that it stopped recording, so I was trying to get it back online. If a patient has any restrictions or assistive devices, I like to, make sure that I know that too. If you've got a patient that's coming in and they've had a stroke and they use a walker, and you're fixing to do a shoulder surgery, and they're going to be in this lovely, lovely sling for weeks, then we're going to have to rethink some mobility issues. So always be sure and see what what their restrictions are and what assistive devices, because we want to know their range of motion so that we know if there's any changes or anything that we're going to have to be thinking ahead of time about. So I just wanted you guys to be thinking along those lines. Now, of course, I talked a little bit about some of the diagnostic tests that you guys are going to be looking at. Now, of course, if there's anything abnormal, if something shows up on the chest x-ray, or it shows up that they're anemic, or things along those lines, of course, we're going to let the physician know any abnormals. There's a nursing diagnosis on page 424, and I put that on here because it's always good, for you guys to be thinking about the nursing diagnoses as you go. And as I'm looking at this slide, I did forget to say something about the translator. There are there are always translators available. It may be at some hospitals you use, a phone system so that you translate and it's over the phone. They don't have, somebody in the hospital per se to be a translator. There are a lot of people that volunteer, that sign. Churches are always a really good place to find signers. Not there aren't a whole lot of people necessarily that know sign language around. So, definitely if you're really having trouble communicating with a patient, definitely call your local churches, because a lot of the really big churches have, somebody that signs during their services. So that's a really good thing to think about. I've learned that over the years. Now let's get over to pre-op teaching. Now, of course, most people are going to be MPO after midnight for, their procedures. And of course, if they've got an afternoon procedure and depending on what it is, they may can have a light breakfast or something along those lines. So that's going to be one of those important things to tell the patient. Now, of course, we like them to not smoke for 12 hours before surgery, but you know how that works. And I've just got a lot of things on here. Now, I always show patients. Now, if they're kids, I do the FACES scale, or, there's the 1 to 10 scale, your pain scale, rate your pain on a scale of 1 to 10. There are those in a lot of rooms, in a lot of hospitals, so that the patient can actually see what they look like. But you need to be talking to the patient before they have their procedure. These are subjective tools. Some people really have a hard time putting they can't describe the pain. They can't, some people are just terrible. They'll just say, "Oh, I feel bad." It's terrible trying to get a description from these patients. So I always do that ahead of time so that they know exactly what I'm expecting from them, and so that they understand that they're going to be doing this. If you're going in hourly to assess your patient and ask them about their pain, and they don't know that you're going to come in hourly to ask them about their pain, sometimes they can get a little perturbed about that. Why are you bothering me all the time? So if they know ahead of time that that's what you're going to be doing, they're a lot happier on the back end of it. So a lot of these things that we do may seem like, well, geez, that's common sense, or why are we doing that? But a lot of times we're doing it to help the people behind us, so that this patient is not so cranky, and so that they understand. And their crankiness or frustration is just because they don't know. Sometimes it's because they don't want to do it, obviously. But if they know that that's our expectations and what we're going to be doing, then they're more likely to tolerate having to do this. So anyway, I want you guys to think about that. Now, their diet is going to be another thing that I always explain on the front end. If a patient's having, if they're having a colon resection, they're not going to be coming back in and eating a regular diet right off the get-go. They may be on a clear liquid diet for a little while. Some people wake up and want a hamburger. So, it's just one of those things that if you tell a patient you're going to be on clear liquids afterward, they're going to tolerate it a lot better than when they come out of the OR, they're starving to death. I haven't had anything to eat in 2 days, and you plop down some chicken broth and a thing of Jell-O. So, really good idea for you guys to tell them that up front. Medicines, blood thinners are something that, depending on the type of blood thinner, whether it's aspirin or not heparin. Sorry about that. Coumadin is what I meant to say. But some of those things they're going to be off of for anywhere from 6 hours to 7 days, depending on what medicine they're on. Because, we definitely, when we're talking about surgery, one of the biggest things that we worry about is hemorrhage, right? If we've got somebody that they come out of surgery and they've got blood on their dressing, okay, we're going to be watching that because we worry about them bleeding out, or their abdomen becomes firm, or that's what we're worried about is bleeding. So we definitely have to be careful about about how thin their blood is. So depending on the procedure, since we're talking about medicines, some some places want them to take their heart and blood pressure pills before they go down for a procedure. One of the outpatient ones, especially. So that's going to be one of those things that you need to know your hospital policy and what the physician's ordered. If there's a question, you can always call pre-op and ask, hey, I'm fixing to send him down for a colonoscopy, and should I give him this atenolol? It doesn't hurt to ask. We'd rather ask than something go awry and do the wrong thing. So, definitely call if you have any questions. You flip over to legal preparation, slide number 14. I'm trying to go through and talk as so that you guys have them on your PowerPoint as we're going through. Now, legal preparation is really, really important. Now, of course, hospital policies are going to vary a little bit from place to place, so it may be one of those things that, you don't know what your hospital protocol is, so you may have to check and see what you need to know about it. But generally, we're always going to ask somebody if they've got DNR orders or if they've got power of attorney or, any of those things. If a patient just goes in for a little simple procedure and, it can be anything just simple. If a patient doesn't have any family member that lives in state and they call their pastor and their pastor drives them to have since I was talking colonoscopy earlier, I'm just going to stay with that one. So anyway, the pastor is there just as the driver, right? There's no other family with this patient. What happens if they get in there, they're doing the colonoscopy, and her bowel perforates, and she's got to go immediately to surgery, and there's nobody there? If there's somebody that's power of attorney or things along those lines, we need to know so that we can give them a call. Of course, in an emergency situation, we don't necessarily have to have somebody there, but it's always good to know just in case. So I wanted you guys to be thinking along those lines. Now, informed consent is something that we always do before somebody has surgery. They have to be informed about the procedure so they can consent to the procedure. So they need to know all about it. Now, this is a legal binding document, so we have to make sure that we have followed the protocol. We want it valid because it's a legal document. So if the patient didn't know anything about it and somebody just brought in a consent form and you said sign it and something happens, well, that informed consent. It wasn't really informed. She signed it, but it's not a valid informed consent. So the patient needs to be competent. They need to understand what they're signing. They have to sign it voluntarily. It's not like we go in there and hold a gun up to them and say, sign this. But, there are ways that you can word things that a patient might not feel like they're voluntarily signing. So a patient needs to know what they're having done, because, they need to know the risks. They need to know the benefits. If there's something else that's an alternative treatment, like if you go in and somebody's got breast cancer and you say you have to have this mastectomy, they don't have to have the mastectomy. If they don't want to, they can choose a conservative treatment. They may say, nope, I want a lumpectomy, and we'll do chemo or radiation or chemo and radiation afterward. That's fine. If that doesn't work, they can come in and have the mastectomy later. But the patient has to understand the risks, the benefits, the alternative treatments, and the prognosis. Those are all key elements for this to be a good informed consent and a good legally binding document. Now, a patient, there are patients that can't sign. Now, if a patient cannot write, they can sign an X there, and that's legally binding because the patient that happens to be their signature is that X. I know that my grandmother, she did not know how to read or write. She would sit there and look at the newspaper every day. Most people didn't know she couldn't read. She'd sit there and look at it and study it for hours. Not know one word on there. I taught her when she was 78 years old how to write her name so she could sign a check. It took her about 15 minutes minimum to sign a check. She sat there and she worked so hard at it, and it was the most beautiful signature you'd ever seen. Most not everybody can do that, though. Some people can just stick with the X. Men typically, more than women, most of them will just put an X there, I've found over the years. I know a lot of people that can't read or write, and so that's a typical thing, especially if you live in a rural area like I do. A lot of people around here didn't go to school. So, they just never learned how, and their family didn't believe that they needed to know. So, these patients are fully functional. They are, some of them are, more intelligent than some people that I know that have gone to Harvard. But it doesn't mean anything. I mean, it's still legally binding because that's how they sign their name. Now, you may have a healthcare proxy or next of kin or a legal guardian sign as well. Those are some people that can sign. But of course, you got to have a witness. The thing about it is that if you're doing something over the phone, you got to have two people listen to what they're saying. If you call and ask for consent from a family member in Idaho, well, you and another nurse need to witness. You need to both ask, do you consent to her having this procedure or him having this procedure? And then both of you need to sign it and put that it was, you had obtained the consent over the phone, so that all of your I's are dotted and all of your T's crossed. Now, typically the anesthesiologist will come in and typically there's a separate consent form for them, so we don't have to worry about that. But when we're doing our pre-op checklist, we've got to make sure that it's complete. And that is something that you guys will see on the test. It's common sense that you're going to do a pre-op checklist and that you want it filled out and all those things. But I definitely will be asking you a question about that. I do have an example of a pre-op checklist on there, and you guys can click that link and it'll take you to it. Now, anytime we're doing our pre-op checklist or we're giving a medicine or anything along those lines, we're always doing two identifiers, right? So usually our patient's name and date of birth. So just be sure that you use that, because we want the right patient, the right time, the right dose, all of our R's to be correct. Now, there's a lot of medicines that are given preoperatively that are given in the holding area. I just put a list on there. Now, gerontological considerations. There's a chart on page 430 and 431 that you guys might want to look at. Now, as you guys know, our older patients, they have a higher risk of morbidity and mortality because most of them already have health issues. Most of them just, aren't the healthiest of patients. Of course, as we get old, everything slows down. Everything, we have all of these issues. So they are at a higher risk for death or, problem afterwards. So just be thinking about that. Now, when it comes to medicines and treatments and everything, you want to start low and go slow with these patients. You're not going to when you get them up walking after surgery, it's not like you're going to walk a mile with them. You're going to take a few steps and then see how you do. So we start low and go slow with these patients. Now, surgery is more prevalent. When we were looking at our statistics, more older patients have surgery. Because as we get older, we have more problems. So that's why we have more surgeries as we get older. But they have such issues that we're watching out for anemia, malnutrition, dehydration, limited mobility, all of these things that throw a kink into our well laid out plan. They have a lot of complications. So these are going to be things that we're going to be taking especially good looks at with our elderly patients. Now, I didn't really put anything about perioperative nursing in here except one slide, and I only did that because this is a specialized area. If you guys work in OR, then you will be trained for OR work. It's one of those specialty areas, so I'm not going to go through a big, huge issue with it, but there are a few things that I did want you guys to think about. Now, when you're thinking about patients in the OR, you think about them going back and they're having their procedure and then they come to you and you're giving them pain medicine and taking care of them post-op or on the floor. They're still post-op, but you know what I'm saying. I'm not just talking about PACU. I'm talking about on the floor as well. Now, I've had a lot of patients that have gone and said, man, my knee is killing me. And, they may have had a bladder surgery. Well, or my neck really hurts when they had a shoulder surgery. So I want you guys to think about positioning in surgery and think about your patient's pain. There's a lot of times now when we're talking about the bladder surgery, since I mentioned that in the knee pain, I want you to think about the lithotomy position. Those legs are up in stirrups with some of these. Your knees are spread out farther than they should be. It really can cause some discomfort for these patients. And it may be in an area that's nowhere close to where they had surgery, but that is something that patients do have some discomfort with. So I want you to be aware of their positioning and think about that when we're talking about pain. You may have to massage their knee, or they may have a catching or a leg cramp or whatever it happens to be. But I want you guys to be thinking about that. And that is not, of utmost importance. But if you've got somebody, I've had some patients with some severe pain. It hadn't been at the surgical side, it's been someplace else. So I want you guys to think about those things. Also, when a patient has something that there's two of, like if it's like arms, typically they don't sign their eyeballs, but typically with arms and legs, we have them take a Sharpie and we have them sign which leg they're going to be doing that they need surgery on. It's one of those things that safety comes first. I have seen case after case of somebody amputating the wrong leg or doing surgery on the wrong leg or the wrong arm, it happens. So that's the reason why we have started doing this a few years ago. Now, also, there are general anesthesia. There are a lot of issues and that, a lot of complications that we can have after having general anesthesia. Damage to the vocal cords, damage to teeth, hypoxia, hypertension, dysrhythmias, muscle paralysis. Sometimes this muscle paralysis is just because they got a medication in the OR that causes this muscle paralysis, but sometimes there may have been some nerve damage or things along those lines that occurred during surgery. So these are things that can happen that we have to worry about. Of course, hypothermia can be one, but malignant hyperthermia. Be sure that you guys know about malignant hyperthermia. There's a little information about it in your chapter. Now, there is also a condition, since we were talking about elderly, that I wanted to throw in. POCD is something. It's perioperative cognitive dysfunction. And that is something that can happen to patients. That's the reason why we do our baseline as well. How were they before they come in? How are they after they come out? They can have issues for years after their operation. So that's another reason, because of POCD is another reason why it's good to have a good baseline assessment. So whenever a patient comes out of surgery, now we're going to be looking at hemodynamic stability, because that's one of those things that we really mess with their fluid status whenever they're having surgery. If they've got while I'm thinking about it, I'm going to throw something in about the perioperative period. Whenever you're in the OR and you're giving a report, well, if you're in PACU and giving a report to the nurses on the floor, you obviously want to tell them how much blood loss or estimated blood loss during the surgical procedure, because that's something that we're going to be looking for. If they had a huge amount of blood loss, and maybe they got a lot of blood during the procedure, maybe they got a lot of IV fluids. All of this messes with their hemodynamic stability. So those are things that we need to know, and we need to think about and, put that in the back of our mind, that this is what we're going to be looking for. The patient may have a blood reaction, a few hours down the road when they come to the floor. And if we know that they got some blood, then we know that that's something that we got to be looking for. So, if a patient, especially a patient with heart issues, if they got 2 or 3 liters of fluid during the surgical procedure, then obviously we may have to think about diuresing them. We're going to be listening to their lungs to see if they sound wet and they've got a bunch of crackles in there. Those are all things that we're going to be thinking about and looking at with these patients. Now, when we're talking about discharge, now ambulatory surgery, that's just one of those things. You get them in there, you recover them. Typically it's for an hour. If after an hour their vital signs look okay, if they are, they may be groggy, obviously, but if they're awake, if they're alert, if they're oriented, if they can get up and dress themselves with a little assistance, then typically they're ready to go home. If they drank them a little juice and kept it down. Of course, in some places they want to make sure that they can go to the bathroom afterward. So those are things that we're looking for. And of course their pain level isn't too terrible. Those are all things that we're looking for to get somebody out of the ambulatory surgery center. They've got all these met. Okay, see you later. You're good to go home. Of course, they've got to have a driver. Is one of those rules. And I told the traditional class about it. I always tell this story to anybody that listens to me. I had a patient, and he had a colonoscopy, and his wife came with him. They were elderly. And so anyway, I said, now, you can't drive home. She's got to drive you home. Yes. Well, we did that in pre-op, and then, put him under, and he wakes up, and it's time to go home. And I said to her while he was asleep, now, you are driving him home because he cannot drive home. Well, she went and brought the car around, put him in the car. He got in the passenger side. They drove off. I watched them out of view until I could no longer see them. I watched them. Well, they pulled over. He took over driving. They were driving in Mountain Home down the bypass, and he drove down the bypass the wrong way. They hit somebody head on. It killed both of them, and it really hurt a lot of people. It was a family in the other vehicle that they hit. So I still, to this day, cannot get past that, and I still feel bad about it, even though I did all I could do. It's really important that you make sure that happens, that they don't drive home, that their family drives them home. If not, if you've got somebody that you're suspicious about, there's been a lot of times I've paid a cab to come get somebody and take them home. I also have called neighbors to come get people. I mean, there's lots of things I've done. I've kept them in the hospital for hours after hour after hour as well, just so that they don't drive themselves home and hurt themselves or somebody else. Now, when we've got somebody in post-op, first thing we're going to do, we get them in post-op, we're going to get that vital sign machine on them, we're going to check their vitals, and we're going to assess them. We're going to see how their lungs sound, all that good stuff. Sorry, my voice is about to go out on me. So, of course, we're looking at their pupil size. We're seeing how reactive they are. We're seeing if they're talking to us. We want to make sure their speech is clear. All of these things that we're going to do. Their pulses, their skin color, can they feel me touching them? Are they moving? All of these things are things that you guys are going to be doing. If they've got a chest tube or a drain, we're going to be checking and making sure that they're functional and what's coming out of them. Because obviously, if we've got let's just say a JP drain, well, even a chest tube. And if it's got a bunch of blood coming out of it, well, we're going to be worried about them bleeding. So all of these things we're going to be checking. Now, of course, we're going to want some, we've done our pre-op turn cough. I always say turn cough deep breathe, but it's cough deep breathe. Old acronyms get stuck in my head. So our coughing and deep breathing and all those things that we've taught them beforehand, we're going to be reinforcing that as they're waking up. Now, I also want you guys to think about, these are common sense things. If somebody's got, you go in and you're listening to their bowel sounds and you're putting your stethoscope on their belly. If it's nice and soft, yay. If it becomes hard and distended, Houston, we have a problem. They may be bleeding internally. All of these things we're going to be watching out for. Now, don't forget, hyperthermia can really happen from anesthesia. A lot of people come into the post-op area actually hypothermic. So, keep a close watch on your patient's temperature. Now, patients come from the OR and they've got a dressing on. Now, what you're watching for is any drainage on the dressing, right? So if blood is soaking through the dressing, you will see a little something on there. You mark it with a pen, and if it gets bigger, you need to do something about it. So just make sure that that you're keeping a close eye on that. Now, whenever we're talking about post-op, we're making sure that obviously if they're coming to us and they may be in the bed for a few days, we're going to be putting our TED hose on or our compressions boots and things along those lines. So I hate putting those things on when patients are awake, much less when they're asleep. They're really hard to get on patients, but really important to be sure that we cover all of our bases with that. Now, of course, we're assessing these patients. If they are a little more awake and things along those lines, and they're getting better, our assessment isn't going to be quite as frequent as they are when they're first out and they're not awake and things like that. So, as a person wakes up a little bit more, comes to a little bit more, and their condition improves, we're gonna feel a little bit better about them. Now, most of the time, we're doing our assessments and vital signs and everything. We're doing it every 15 minutes times 4. So that's our first hour taken care of. Then the next hour, the second hour, it's going to be 30 minutes times 2, and then hourly. And of course, depending on the condition of the patient is how we're going to change that around. Now, we reposition our patient every 1 to 2 hours. Of course, it depends on the surgery that they've had because, obviously there's some things that they can't be turned on their side for if they've had a certain procedure. So those are things to consider. But, a patient can have a skin breakdown after 2 or 3 hours. So that's the reason why we're, making sure that we're turning patients and keeping that skin intact and we don't want a pressure ulcer or any issues like that. So most of the time when we get a patient in post-op, they've got their oxygen on. We don't want any hypoxemia. So we're going to make sure that that upper airway is supported. They've had a tube down their throat. So we want to make sure that there's no swelling, that they're breathing okay, that their breathing is good, because sometimes when we give them this medicine that makes their muscles weak, our diaphragm is a muscle, and our accessory muscles help us breathe. So we definitely need to make sure that they are getting some good deep breaths in there. Now, don't forget, we're doing eyes and nose, and we're keeping a really close eye on that. Now, we already talked about our drains and things, so that's going to be really important. Of course, their urine output, we're watching that to make sure that there's no kidney issues. So we want at least 30 mils an hour of urine coming out. So, be sure, because we do have to worry about hypovolemia and hypervolemia, and of course bleeding. So be sure that we're doing a good I&O on these patients. Of course, we talked earlier about a patient with heart failure. We've given a whole bunch of fluids, so we really need to watch them closely as well. We really worry about them. So around the incision sites, most of the time they're covered. But now if we're talking about somebody that's had a heart cath, let's just say, we're looking for a hematoma there. We're looking for bruising. If it hurts, we're looking for a hard area. Now that's around any incision site, but a hematoma is really one of those things that can be really common with a patient that's had a heart cath. So I just wanted you guys to be thinking about that. So whenever we're talking about fluid losses, typically we lose about 600 to 800 mils a day. Now, after surgery, it can bump up to 1,500 mils. So, I just want you guys to keep that in mind. Now, patients that come out of surgery, they typically have, that stress, that pain, that anxiety. And so what happens is, on a biochemical level, we get epinephrine and aldosterone and antidiuretic hormone released. And so all of these things contribute to fluid overload as well. So, that's another reason why we really keep a close eye on the I&Os and their vital signs, because obviously, those will change as well. I really think that's all I was going to talk about there. Of course, complications. I want you guys to be sure and tell patients if they have had, a lap, that they blow you up like a balloon. I mean, you don't have to tell them like this, but I personally was not told about all of this, and I was a kid, and I thought, oh my gosh, what is wrong with me? I shouldn't be having chest pains, and all of these things. But, tell them that they fill you up with carbon dioxide gas, and they suck out what they can, but some of it's still left in there, and it's got to work its way out. And so it's gas, it works its way up. So if you're laying down, it typically manifests itself as chest pain. And, a day or two later, you're up and walking. So it will hurt in your shoulder, your trapezius muscles. It feels like somebody just pinches the poo out of them. So be sure and tell your patients that, so that they are aware of that and know that that's a potential side effect. I wish somebody had told me that, so I didn't have to worry myself so much. Now, patients will come out of surgery, and sometimes they've got PCA pumps. You don't want the family member pushing that button. You want the patient pushing it. So you're going to have to tell them that. Now, we talked a little bit about respiratory depression. Of course, sedation, nausea, slow in the GI system, and itching are all complications that we're going to see from these medicines that are in those PCA pumps, and from pain medicine, opiates. Those are all things that are common with those. So be sure that the patient and the family knows all of these things, so that they know what to do about it, especially after they're discharged home. About the constipation issues are really, people get really fixated on, I haven't pooped in 5 days. So if you tell them that on the front end and tell them what to do about it, they're going to be a lot more compliant and a lot happier patient. Now, if we've got somebody that's got an epidural or any of those things in place, we're going to be looking for infection, right? And of course, if they've got this in place and it stops working, then we need to take a look. We may have to pull off that dressing and take a close peek, because it may be that tubing is kinked. The longer that they lay there with those things, they just bend, and it's just really hard with them. Sometimes you just have to squish the tubing back and tape it in a place so that the tubing won't kink. So just be sure to think about those things. Now, if we've got a patient with liver problems, we're going to watch out for too much Tylenol. They need to know that. If we've got a patient taking a bunch of NSAIDs, we need to, be sure and let them know that ulcers is going to be an issue. So give them, these are the symptoms you need to look for. If you have issues with that, or if you're taking 16 ibuprofen a day, then Houston, we may have a problem with some of these things. So that's why we ask preoperatively what they take, so that we can anticipate postoperatively what to look for. Now, the first thing that we want to make sure our patient is passing gas and passing stool, right? Because we don't want an ileus to pop up. So that's something that they need to know about. If you're not passing gas, if you're not passing stool, we want you to give us a call. Also, there's a lot of issues with patients and their bladders. So, if we've got a patient that we're kind of concerned about, they're having just the minimum amount out, and especially if they say, I feel like I need to pee, get that bladder scanner out and use it. It's great. They may need an in and out catheter. They may have to have a Foley. Even if they're going to be discharged home, sometimes they discharge them home with a Foley. So just think about those things. Now, typically, and I put this on here, and don't laugh, because this is the way it's supposed to go, the first dressing change is done by the surgeon. And I put in parentheses, he takes it off anyway. Most of the time he does take it off and look at it, but we're the ones that redress it. So anyway, somebody needs to look at it. He really needs to look at his work and make sure that it looks okay. Now, we already talked about marking the drainage on the dressing, so we can see if it's expanding, if they're bleeding, all those things. Now, typically if we've got some drainage from a wound, there are some things that are going to ooze more than others. Skin grafts are really bad. They like to, put off a bunch of serous drainage, serous sanguinis to begin with, and then serous. So, just depending on what we're talking about. But a lot of times it starts off the serous sanguinis. It's clear, but got a little blood mixed in with it. So it's kind of a really thin blood, not a, frank blood. And then serous is just more the clear fluid. So I want you guys to remember the differences in those. Now, don't forget to do your drains. Empty them every shift at least. Some hospitals are different. Most of them are every shift. Of course, if it's pouring out and your drain's filling up, obviously you're going to have to do it more frequently. But the thing to remember is that, they keep those drains in until they're not draining. If, once you've got everything sucked out of there, then you can pull the drain. So that's the reason why we keep, and we're watching it, the amount out to go down and down and down. Now, don't forget, because I have had people do this before. It's bad. It's just like pulling a Foley out. Would you deflate the balloon on your Foley before you pull it out? Well, please tell me yes, you would do that. It's the same thing on like a JP drain. You obviously want to let the suction go. So pull the little stopper, let it fill up with air, and then pull your drain out before you do that, because those things operate on negative pressure. So if you do not do that, it will keep on sucking as you're pulling it out, and it is very uncomfortable to do that. Plus, it obviously can damage some things. So just think about that as you guys are doing that. Now, there is a chart on VTE prophylaxis on page 475. Now, remember that the venous thromboembolisms, that is a pulmonary embolism and a DVT, right? I put some statistics on there so you guys could see. Now, these are from different sources, so I know that they don't add up to 100% when you look at them, but those are some estimates that I found in different places. So up to half of patients with hip fractures have a DVT, and it's estimated that 20 to 30% of patients that have general surgery have a VTE of some sort. So, of course, anytime we're worried about this, we're going to try to prevent as much as we can with medicines. Coumadin, heparin, Lovenox are all things that we're going to be using for these patients. We want to try to keep the INR between 2 and 3, and they're going to be on these drugs for several weeks. Of course, we're going to be doing our compression, whether it's our hose or our boots. Early ambulation is one of those things that we can use as well. If you've got somebody that's stuck in bed, the best thing they can do is move their feet and legs. I mean, that's what you want them doing. That is a great thing. We're getting that circulation going. Even though they may not be able to get up and walk, they're still moving. We're still keeping that blood from pooling, and we're trying to keep that clot from from forming, right? So, really important that we do that. Now, the gerontological condition